My name's Mike Mugavero. I am a co-director of the UAB Center for AIDS Research and a co-investigator on our Implementation Science Hub. Really pleased to welcome you to this webinar today, and thank you for joining us. We're really delighted to have Doctors Joshua Richmond and Navneet Badwan speaking to us on biostatistical considerations for implementation science. And maybe we could use I would love to just use the show of hands function in the chat. If there's folks who this is their first time coming to one of our IS Hub webinars, if folks could just raise their hand and would welcome you. And also would certainly welcome anybody returning, but want to thank folks for being here, whether it's the first time with us or returning. And if you haven't, please join our listserv. I think try to offer some good programming and information, but welcome. There's several folks here for the first time. We're really glad to have you. So really excited about this session today. We have two speakers, Dr. Joshua Richmond, who is an associate professor in UAB's Department of Surgery, is an MD, PhD. He is the Director of Biostatistical Services for the Institute for Cancer Outcomes and Survivorship at UAB. And his research interests are broad and has done some really great work across a number of different disease areas, but really focused on methods in health services research, biostatistics, statistical methods for observational studies and clinical trials, risk prediction, machine learning, and Bayesian analyses. So, Dr. Richmond, Joshua, thank you so much for joining us today. Also, really excited. So, on the flyer, you might have seen that Dr. Tapan Mehta was going to be a speaker. He's been replaced, and we're really excited to have join us Dr. Navneet Badwan, who is a research science specialist in the Department of Family and Community Medicine at UAB. She is the deputy PI of a HRSA-funded top-up rapid response center that was recently funded. Is also a co-investigator on an NIH-funded big data methods in health informatics core, as well as the associate director for an affiliated design analytics core within family and community medicine. And through these roles, she's done grant writing, analytic support for trials, a number of methodological designs, including optimization trials, as well as quasi-experimental and observational studies. So we'll be turning it over to them, but want to let folks know that we will have a post-webinar survey right after the talk, and we greatly appreciate feedback, any and all feedback. Also, to let everyone know that the recording and slides will be posted to our website within the next 24 hours, and you can find that link will be available in the chat. And so with that, again, thank you for being here, whether you're first time or a return visitor to our webinars, and we'll turn it over to Drs. Richmond and Badwan.
Thank you. I'll begin today's presentation. Just a little bit of introduction, and this was already covered. I'm a research scientist specialist. I help support the big data methods and health informatics core. This core has an admin core, MHI core, and dissemination implementation core. This is our consultation form if of interest. So moving over to the presentation today, this is the translational research pipeline. And traditionally, research efforts have gone from efficacy studies, which are in tightly controlled environments, to effectiveness studies, which are more real world, and then finally to implementation science research. However, this resulted in a long wait for evidence-based practices to be implemented. And so lately, Curran and all in 2012 posted one of the earliest papers where they introduced hybrid designs, which integrated the effectiveness and implementation research in hopes to reduce that time gap between evidence-based practices being implemented. And we'll talk a lot about implementation research strategies, including hybrid designs, in today's presentation. So moving on with the definition of implementation science, I think this one is really interesting. There are multiple definitions, but the one I have here today describes it as a scientific study of methods to promote the systematic update of research findings and evidence-based practices into routine practice, and hence improve the quality and effectiveness. So this definition inherently makes implementation strategies precursors to effectiveness. So these are leading indicators to effectiveness outcomes, which may be your clinical outcomes, the person level outcomes. The field of implementation science seeks to systematically close this no-do gap. Curran et al. Again propose very simplified definitions for implementation science. Under this definition, the concept, which is your intervention, is called the thing or the intervention you want to conduct. Effectiveness research is then testing if the thing works. So in your control group versus the group that gets the intervention, is there a difference in the outcomes? Then implementation research assesses how best to help people or places do the thing, and implementation strategies are the stuff we do to help people do the implementation. Then implementation outcomes assess how much and how well do these people or places do the thing. Now, notice the difference going on to people or places. So a lot of times we'll see later that implementation research may be at a site level, place level, provider level. These are some very broad outcomes for implementation and effectiveness research, and I have in the very end, I post a link to a paper which describes these in detail and does a really great job. So in implementation research, your primary focus is on the effect of your deliberate and purposive actions to implement new treatments, whereas in effectiveness research, you may be looking at the clinical, behavioral, or patient level health changes. The core questions are, again, as I mentioned, in implementation research, maybe at the provider level, systems level, if they adopt and execute the thing or the intervention. And in clinical effectiveness research, we want to see if the thing worked to improve, say, your clinical outcomes and under real world settings. This is a key distinction from efficacy versus effectiveness trials. Again, I say trials, but I want to reiterate that implementation science is not limited to trials, but trials is the focus of today's presentation, but they have been implemented in observational context, in program evals, and quasi-experimental studies as well. The keywords in implementation, the key domains in implementation outcomes could be acceptability, adoption, uptake. Adoption versus uptake is another distinction. If we have time, we can talk about it. Appropriateness, feasibility, fidelity, implementation costs, re-aim based outcomes. Then in effectiveness outcomes, it could be your regular clinical outcomes. Um, that are more looking at quality of life like indicators, also a distinction from efficacy outcomes. As I mentioned, for the position in keychain, implementation outcomes uh, are the leading indicators for your effectiveness outcomes. This is a very interesting translational research subway gap curated by Lanefall and Curran et al. So basically, there are three steps along this pathway, and you want to identify at which stop you are at. And this begins with you identifying the practice of your interest. And the first step is to identify if your practice of interest in your context has strong efficacy data. If it does not have strong efficacy data, you may want to do efficacy research first. If it does have strong efficacy data, but the effectiveness is not shown or it is partial, then there are approaches. You can either establish effectiveness first, but like I mentioned early on, that hybrid trials would cut that time between if evidence-based practice is going into implementation. If you can do the hybrid effectiveness implementation trials. If then you have very strong effectiveness data that has also shown that depending on how it may needs to be adapted in the setting that you're going to implement in, you can look at different strategies, mixed method type studies for designing and test, and other strategies for designing and testing implementation strategies. Um, Again, going over to hybrid effectiveness implementation trials, there are three types, the type 1, type 2, and type 3. Type 3 and type 1 are the opposites of each other in the sense that type 1 primarily focuses on clinical effectiveness. So the unit of analysis is person level. While doing that, you're also gathering information for implementation context and strategies. So all effectiveness studies may use some implementation strategies to deliver the intervention. Now the thing is that in these studies they may be using rigorous fidelity checks. There may be an incentivization protocol. However, a lot of this may not be scalable to a real world setting, but you can learn from this information. You can learn what may work, what may not work, what may needs to be adaptive to make a finalized implementation strategy package. Type 3 is the opposite. In type 3, you have, there are implementation strategies that exist, and you want to now test them formally while also collecting secondary data on clinical effectiveness. There could be multiple reasons why you also want to collect clinical effectiveness. In this case, maybe to establish fidelity or adoption, or in some cases there is an intervention that is just rolled over. Health systems have decided to adopt this certain strategy, and now you have it, and you don't have effectiveness data, but you want to test it while implementing the strategies. Type 2 is the middle ground between type 1 and type 3, where the focus is dual: clinical effectiveness and testing implementation strategies. And depending on your research question and what your primary, I mean, both are dual, and what you're wanting to seek, you may discuss the research design you may want to use. There are a couple of options here. Sometimes you can do a dual randomization. So for the implementation strategy, you may randomize sites to the strategy, and then within sites, you can randomize people to the intervention. A way to do that could be 2 by 2 factorial experiments, or you can do a multiple arm RCT. Then there are other types here in type 2 hybrid, where maybe you're randomizing to the intervention, but you do a non-randomized one arm only implementation strategy assessment. These are hybrid types and their examples, and we'll talk in detail about two of those examples. Type 1, again, because it's more familiar to us, which the primary focus is clinical effectiveness, and I tried to pull together a hypothetical example here, where you may want to evaluate the clinical effectiveness of a CGM or RPM intervention on hemoglobin A1C reduction and time in range, while also characterizing the clinic workflows, the barriers that may exist in a early pilot study. A real world example is the Rainbow trial or the Hat Trick trial. Then type 2, which are dual focus, equally balanced. You have clinical effectiveness. You're assessing clinical effectiveness and implementation both. They should not say secondary focus, sorry. The example for this that we will be discussing in detail today is the Cradle 5 study. um, and then the third one is type 3, which is an implementation strategy, and the secondary focus here is the clinical effectiveness. So the primary question is, does the implementation strategy work? An example again that we will be discussing in detail today is the Digits trial. Before we discuss Cradle 5 and Digits, I wanted to introduce the study designs that they are based on, just in case. So we will see that one of the study designs is a step-wedge CRT, and then we'll also have a SMART going forward that we will be discussing. So I wanted to talk about the step-wedge CRT, and I'm assuming cluster randomized trials are more familiar. In step-wedge CRTs, clusters sequentially move from control to the treatment groups over a period of time, and there will be sample size considerations that Dr. Richmond will be talking about for both of these in a little bit. Although research designs are not tied to the hybrid effectiveness implementation study that we're doing, however, if if we were to pick one, type 3s or type 2s where your primary, you want to focus more on implementation, you may be looking at cluster randomized trials. And then the other one are optimization trials. So optimization trials differ from traditional studies in the sense that they're focused on building and refining efficient and scalable interventions while taking resource constraints into consideration. And multi-phase optimization strategy is a premier engineering-based framework that has been adopted in clinical behavioral and health services research to implement optimization trials. The most framework has three phases. The preparatory phase, where basically you're coming up with the conceptual diagram. You're trying to establish the theoretical and empirical uh, rationale for the interventions you want to assess. And then you move on to the optimization phase where you have now identified individual components that you want to assess. There are two ways that we discuss here that you want to do that. First is using a factorial experiment, and the second are smart sequential multiple assignment randomization trials. In factorial experiments, you will identify individual components and the interaction between them and what forms the final package, which includes all active components. Smarts follow sequence of decision rules. What do you do first? Then something happens. Then what do you do next? So there is a second randomization. Uh, Usually it's two randomization. So there is a second randomization that may happen later. And then the third is the evaluation phase where now you have a package and you assess it in a rigorous RCT. So moving over to our first example, Cradle 5. Cradle 5 had precursors. This was in Sierra Leone. Cradle Vital Signs Alert, which is a low-cost intervention, a handheld, semi-automated, low-cost blood pressure and heart rate monitoring device, which was associated with reduced rates of eclampsia and maternal death. The implementation was piloted and evidenced by measures of fidelity, feasibility, and adoption. Then Cradle 5 was designed as a type 2 hybrid step-wedge CRT. Cradle 5 was optimized using a pilot study that happened before it. This step-wedge CRT was a pragmatic mixed method study. So their process and scalability measures were assessed using interviews and direct monitoring, focus group discussions. And then I'll talk about clinical measures. The goal was to examine whether a national level scale up. The precursor study tested this intervention in 10 urban regions, and 10 urban regions. Now they were going national with rural inclusion as well. And they wanted to see if it reduced the composite outcome of maternal and fetal mortality and maternal morbidity, and evaluate how it can be embedded into routine clinical pathways. Um, so I guess the primary outcome was the composite score that I mentioned. The process and scale-up evaluation of the protocol was assessed via a mixed methods approach, and it included looking at the routine data, qualitative interviews, focus group discussions, direct observations. Uh, the other measures included, implementation measures included fidelity, adoption, adaptation to intervention, and then the scale up outcomes were reach, maintenance, sustainability, and integration. Then this was another study that used a factorial experiment approach. So two known treatments for substance use disorder exist, Reset and Reset O. Reset is, these are smartphone app-based interventions. Reset is for substance use disorder. Reset O is for opioid use disorder. Digits trial was was a type 3 cluster randomized trial that sought to identify uh, so before that, Reset and Reset O had been evaluated in specialized settings. However, the research team had indicated that these have applicability in primary care settings because Reset O had could offer prescribed buprenorphine, and they were seeing a lot of and there are a lot of substance use disorder patients who have active substance use that could be managed in primary care setting. So this is what this trial was doing. They sought to implement this in primary care setting. Again, this is a FDA approved smartphone app. They wanted to evaluate whether practice facilitation and health coaching can improve the deployment of this tool. And the main focus was evaluating the implementation outcome consistent with the type 3. Secondarily, they evaluated population level effectiveness and cost effectiveness. Cost effectiveness for type 3 is crucial because you want to know what is the cost effective dose that results in the clinical outcomes that you're going after. Then they randomized 22 clinics, 21 sites. Two of the clinics were really close to each other into four experimental conditions. The first one was standard implementation. This was just some educational tool, live or video recordings that the clinicians could look at. The practice facilitation was somebody on site integrated within the system who was helping with the adoption. And there were patient and clinician facing components of that. Then there was a health coach component. Um, yeah, the primary outcomes were reach, proportion of patients who initiate the digital therapeutic, fidelity, mean number of weeks during patients' 12-week prescription in which patients use the module and have visited the clinicians in past 30 days. Secondary outcomes were engagement, economic costs, and the other outcomes they were assessing was substance use and abstinence. Then this is a smart-based implementation study where rep is replication, replicating effectiveness. I forgot it. Oh, replicating effective program. This is an evidence-based program, evidence-based framework that has been tested in HIV settings. However, they were now using it in for psychosocial mood disorders. And the researchers had found that in this setting, the adoption rates were much lower. So what they first did was there were 80 sites in this study. There was a run-in phase where rep was offered to all sites, and then those that were non-responding were randomized either to external facilitation. Again, there was pilot data talking about external and internal facilitation and how that could improve adoption to rep. So they either were randomized to rep plus external facilitation, which is somebody at a central location providing support, and then external or internal facilitator, somebody embedded within each site. Then at 12 months, they identified responders versus non-responders, where for responders, follow-up assessments were continued and non-responders were re-randomized either they continued rep plus external facilitation or internal facilitation was added. Then again in this group, non-responders continued their rep plus external facilitation or internal facilitation, and assessments were made at 18 and 24 months. For further details on this study or each of the studies, I have their resources mentioned below. And moving over to the next part, I'll hand over to Dr. Richmond.
Thank you. That was very informative. I appreciate that. So I wanted to talk about more statistical issues and pitfalls of these kinds of clustered trials. You can go to the next slide, please. I just wanted to tell you, I'm going to emphasize a very few really important issues that are brought on by clustering and the ICC, which is otherwise known as the interclass correlation. I want to briefly touch on things that are clustered but not cluster randomized, and then go a little bit more of an overview of simple cluster randomized trials that you probably encounter all the time, and then more details about stepped-wedge trials. Next slide, please. Just as a disclaimer, I generally make pretty boring slides. I don't really want to read them to you verbatim. I don't really want you to necessarily try to read them while I'm talking because they won't say exactly the words that are coming out of my mouth. I think I should learn something from having to give a talk, and y'all should hopefully learn something by coming to the talk. And it's impossible to say exactly what that should be because, you know, I didn't hear what Navneet was going to say before I'm talking, and I don't want to reproduce it. And there were some things that she said that made me think a little further from what I thought when I was putting the slides together. Next, please. And I want a big just reality disclaimer about the world. We always plan and talk about how we should do studies based on assumptions. Real data doesn't ever do what you think it will do. Real data has surprises. So whenever you're designing a study, you should really keep in the back of your mind that the world is not going to work out the way you plan. So you should never sort of plan a study within an inch of its life, trying to get exactly the minimum amount of sample that you need or the minimum number of clusters that you think you need, because almost always you're going to be less lucky than you think you are. And you'll wish you had more data in one way or another, or you had a little more flexibility. So something to keep in the back of your mind as you go through your life. So the important issue of clustering, all of classical statistics are based around the idea of a random sample where each observation is supposed to be independent of the others. But the world comes in clusters. We're all grouped by counties, we're grouped by zip codes, we're grouped by the streets, the buildings we live in, who our families are, who our employers are, etc. That in itself is not really a problem. The problem, or not even the concern for statistics, is when your sample is actually clustered by design, meaning you don't reach out into the world and find everybody that you're interested in your study, like all primary care providers in North America, and sample them at random, but really you have to limit yourself somehow. You are limiting yourself to only sampling primary care providers in a certain number of clinics that you've identified from universe. So you no longer have a random sample of all the primary care providers, you have a clustered sample from the get-go. Next slide. And the reason that you do that is, well, because processes, procedures, and outcomes vary by clusters. And the thing of this is a lot of things, especially in implementation research, what you might be interested in is, say, how well is a particular clinic or is a particular strategy improve guideline concordant care? That's a process of care. It may or may not affect an efficacy outcome or effectiveness outcome like a clinical outcome for a patient, but you want to know, are they doing what they're supposed to be doing, right? And a lot of times those things are very dependent on local culture. So if you pick a healthcare system that is private and well-funded in the Midwest, their baseline performance may be very different from a publicly funded one in, I don't know, the Mid-Atlantic. So there's a lot of baseline variability that's already built into these clusters. So when you sample by cluster, you sort of inherit that. And therefore, sampling of providers within these large medical centers, they're not independent. More providers within a particular center are much more likely to be similar to each other than they are to the sort of hypothetical random sample out there in the world. This similarity is ordinarily quantified by something called the ICC, the intra-class correlation, and it measures how much of the variation is sort of between clusters rather than within clusters. I just want to point out here also the ICC, if you Google it and try to get a good explanation. I'm concentrating so hard right now, I'm so still that the light sensor has gone off in my office, which is why I think it's suddenly dimmed. So the ICC, if you Google it, what you're going to come up with is an intra-class correlation for measuring how well raters agree with each other. That's the most straightforward thing people talk about. And in that world, having a high ICC is good because you want raters to agree with each other and agree with themselves. In our world of cluster randomized trials, clustering is usually something we try to avoid. So just be careful what happens if you try to Google this afterwards. Next slide. So we sort of touched on this already. Why do you randomize at the cluster level? Frequently, you don't really have a choice. There are practical considerations. You can't reach out into the world and identify every primary care provider out there. You have to start somewhere, and usually that's by finding a system or a hospital or something and looking within their healthcare system. It's harder to find all the independent providers out there and just truly get a random sample. A lot of times intervening on a random sample is difficult, again, especially if this is an implementation trial. You want to change a whole system's behavior or change a service's behavior, and then you wind up measuring it at a smaller level, but you can't decide to randomize how a practitioner treats each one of their patients individually, especially if you're trying to promote a certain kind of behavior. So you have to randomize at the clinician level for what you tell them to do, or even within the system level. There are also issues of contamination, which are adjacent to those, and especially troublesome for implementation research. If your goal is to change the practice of an organization at any level, you really want to try to switch the behavior at that level. And if you try to get half the providers in that organization to do things one way and the other half to do things the other way, you can cause confusion. They talk to each other because people do that. And then some of the people who are randomized to do one thing talk to the ones who are randomized to do something else and say, that was a really good idea, I might do that. And there you've just got contaminated your findings. So the take home for this really, in my view, is you have to at least think about clustering at pretty much everything except a single center patient level trial. And even then, you still may have to think about it a little bit depending on what kind of intervention it is. The sort of gold standard of not having to worry about it is if you've got a drug trial where you're giving people drug A or drug B or drug A or a placebo. And there you really don't think there's going to be much effective clustering. But anything else, especially that involves interactions between physicians or caregivers or administrators and people at a lower level of organization, you have to at least think about whether clustering is an issue. And if you try to design a study and don't think about it, somebody is going to tell you in a very harsh way that you should have thought about it. Next slide. So the next issue is, how big a deal is this? I was grateful. I thought for a long time it'd be kind of interesting to look and see how obvious problematic clustering is. So I actually made some simulated data just for this talk. I made 101 different simulations where I randomly generated 100 clusters per simulation with 100 patients or whatever observation level you want per cluster. And I made each simulation have a different level of intra-class correlation. So that gave me a total of 1,010,000 rows of fake data that I'm going to show you a sample of on the next slide. So this is just a simple panel where I didn't plot all of the data, obviously, even for each simulation, because that would be too big, but I plotted a random sample of 10 clusters and all the data from those 10 clusters. The clusters are color-coded, and the cluster means are those little black blobs sort of in the middle. So the top left is where the intraclass cluster was, correlation, intraclass correlation, the ICC, I'll just say ICC because it's easier. The ICC was negligible. It was basically set to be nothing. So there's a little bit of sampling variability, but it should be 0. The top panel on the right is an ICC of 0.02, which I chose because 0.02 sounds like a very small number. Like, who cares about 2% here or there? Bottom left is an ICC of 0.05, and the bottom right is an ICC of 0.2. Next slide. You get the next one. There should be one just in the middle.
Sorry, my thing doesn't stop working.
Well, we don't have to go to the next slide right away.
Can I reshare? Try again.
While people are listening, the main thing is the next slide is going to say, how different do those look? And we can't really all shout it out, but think about whether they look different, and then we'll show it again.
No. Me. Try here again. Okay.
Yeah. So next slide. So to go back, sorry, back before this one. So the question was, how different do they look? Into my eye, there we go. It was what I remembered it was. So do they really look that different? And to my eye, now we can go to the next slide. After you think about it, not looking at it. The top row, they don't really look that different. If we're just looking at the data, it doesn't look suspicious to me. I should say, I also plotted all these on exactly the same scale, so they look like blobs. When I look at them, it's not like they get messier and messier in an obvious way. The bottom left, it looks to me like there's something else going on, but if I hadn't plotted the means by cluster, I think you'd agree they don't look like much of anything is happening. And then the bottom right with an ICC of 0.2, which makes most people designing studies sort of gape with horror, there you see that there really is starting to be separation in the cluster means. Okay, so now that we've seen that like an ICC of 0.02 or 0.05 doesn't really look that different from a negligible ICC when you just look at the data, we can go to the next slide. So the question then again is, so what? So the real issue is each observation in a cluster has less information than an independent observation because they're not independent. If the analytic methods don't account for the clustering, then your results are too optimistic. Your p-values are too low, and your type 1 error is too high. The practical thing when you design things is that when you account for clustering, it reduces essentially the effective sample size. So your clustered sample gives you less statistical power than if it were an independent sample. And if there's one thing I want you to learn from this, which took me a fair amount of time to internalize, is the maximum real effective size per cluster is roughly 1 over the ICC. So go to the next slide, please. So that means if you've got 10 clusters and your ICC is that fairly innocuous sounding 0.02, your maximum effective sample size for your 10 cluster trial is 50, that's 1 over 0.02 times 10, which is 500. So you could recruit 1,000 people in each cluster, giving you what you think are 10,000 people, but the effective sample size is really not going to go above 500. Similarly, if you have an ICC of 0.05, which is high, but I have seen those things happen in clinical trials of patient-level clinical outcomes, your maximum effective sample size with 10 clusters is about 200. And an ICC of 0.2, your maximum effective size is now down to 50, or 5 observations per cluster. So even a small ICC can have a big implication on your study design. And that's what you should really think about. And that's why when you're designing a study, go in with your eyes open and figure out ways that you can minimize or at least best deal with clustering. Next slide. So simple cluster randomized trials. These are, everyone probably is at least reasonably familiar with this. Essentially, you do a regular randomized trial, but instead of randomizing patients, you recruit clusters, whether they're hospitals, health systems, practices, whatever, and then you randomize at the practice level. And then whatever level your outcome observation is below that, whether it's practitioners, whether it is patients, social workers, whatever, beyond there, you analyze everyone's outcomes at that level, and everyone who's within a cluster gets the same intervention or lack thereof. And then the simple thing that has become much more routine, at least during my career over the last 20 years, is you can choose an analytical method that accounts for the clustering. There are lots of options. You can use mixed models where the cluster is a random effect. You can use generalized estimating equations. You can analyze at the cluster level. So you can literally collapse and get an average outcome per each cluster and do it that way. Then you no longer have a clustered observation. Now you essentially have a random sample of clusters that were available to you, plus or minus a few considerations that you might have. There are some sticky issues that come in there. The mixed models in particular do a better job of accounting for things like unequal sample size. Whereas if you simply analyze at the cluster level and collapse things, it treats your mean observation per cluster the same whether you had 1,000 people that chipped into it or whether you only had 3. So there are things to think about there. Another one which has fallen out of favor is using fixed effects, where you essentially include a term in your model for each cluster that you have. There are good and bad points for that. The usual bad point given for it, well, there are two usual bad points. One, if you have a lot of clusters, that means you're burning a lot of model coefficients, having one for each cluster. The second one is the usual distinction given between the mixed model approach and the fixed effects are mixed models give you a reasonable statistical framework to generalize what you find beyond the particular clusters that you chose, and the fixed effect approach doesn't really do that. So it sort of limits you in the statistical framework to saying this is what happened in these particular ones that we observed. And I mentioned I wanted to briefly say that just about any clustered design, so anytime you do a multi-center study and you know you haven't picked from the world of all the available patients, you've picked 3, 5, 10 centers from all the available centers and then looked within those, should also account for clustering, even when you randomize at the individual level. There's a lot of variability that happens just at baseline at different centers due to local culture, local practices. And if you don't account for that, it will potentially bias or skew your results. And there's a large statistical literature saying you can't ignore that just because you've randomized at the individual level. Next slide. For designing things, people say, how many clusters do I need? The simple answer from any biostatistician is probably going to be as many as you can get, recruit, or afford. No statistician is ever going to tell you that you should have less data than you could have. The semi-simple answer is you probably need at least 3 per arm so that mixed models are even theoretically viable, and mixed models are really what people seem to prefer both in the design and in understanding and disseminating results. The more nuanced answer is to consider how much variation is there among clusters. You can make a case, it may be a hard sell to people, that for whatever process you're looking at, you expect very little baseline variability and maybe it's not that important. So knowing something about the content area and how much variability there is really important. And I just want to remind people that bad luck does actually happen in the world. And the fewer clusters you have, just like in the smaller trials you have of any kind, the more likely you are to wind up with imbalances due to randomization. You know, if you randomize 10,000 patients, you'd have to be extraordinarily unlucky for them to be meaningfully imbalanced at randomization. If you randomize 4 patients, you only have to be a little bit unlucky. And the same goes for clusters. And then the power of these trials is usually based on using the ICC. If you're really lucky, you'll be able to measure one using preliminary data at baseline. If you're even luckier, someone may have published a paper where they actually reported the ICC when they did a similar study. And if not, you usually wind up having to make an array of guesses of here's how power is going to be if the ICC is 0.05. Here's what it's going to be if the ICC is 0.1. Here's what it's going to be if we're lucky and the ICC is so small we don't care. Next slide. I just wanted to show you, like, for that ICC of 0.2, which is possible, especially in an implementation study where you're looking at changing the practices in a healthcare system where there's already wide variability in how well they're following best practices. If you randomly chose the group on the right in green to get the intervention and the group on the left to get the control, then your groups are already different. And there's only so much you can do after that to overcome bad luck. Good analytic methods will help you, but especially if you weren't attuned to it and thinking about it at the beginning, it can lead to real trouble. So just remember, and this was a plot of 10 random centers picked. If I'd showed you a plot of 100 of them, it's a lot less likely you're going to actually randomly choose different groups at baseline for intervention and control. Next slide. So again, the power is usually based on using the ICC to find the effective sample size. There's a nifty formula that in retrospect I wish I'd put there that's not too complicated. The main thing to keep in mind is your ceiling is really going to be 1 over the ICC. And the more people you put in a cluster, the less effective use you have of those people. So the ideal is to not have a clustered sample at all. So you have 1 person per cluster. anywhere in there, the goal would be you want to have essentially as many clusters as you can with relatively few people per cluster, because every time you add more people within a cluster, you take a hit on the sort of additional information you get from each new person in a cluster based on the amount of the ICC. Next slide. All right, the last thing we want to talk about was the stepped wedge. Navneet already showed a very nice slide of what a stepped wedge looks like, but to reorient ourselves, here you go. This is one I helped design, I think, earlier this year. Sometimes you're lucky enough in this one, like year one, where sometimes you can actually collect data for a long period of time before intervention. But the more classic thing is you start off collecting baseline data. Here it starts in the first half of year two, and then those blue boxes are when the intervention happens. So you notice that each of 3 sites here has at least some baseline data collection, and then they all have intervention collection, and hopefully you can continue baseline data collection for each site until they start the intervention, and then you move on. Next slide. So stepped wedge designs are also cluster randomized. Here, instead of randomizing to get the intervention or not, you assume every cluster is going to get the intervention. But what's randomized is the start time. So you don't start off deciding you want to give either your best or worst sites the intervention first or last. So you don't game the system that way by how well you think sites are going to do. You randomize them to that extent so you can't have too much control. But every site is going to get the intervention. Next, please. So this is an especially popular design for implementation and quality improvement, because a lot of times you know there's something that's been proven to be effective and you want to roll it out everywhere and you don't want to stop doing it, but you don't know necessarily whether a particular implementation strategy to get everyone on board is effective. So, and you think about it ahead of time, thankfully, and you think there should be a real evaluation going on. So this is a very popular way to have a real evaluation as things go forward. Sometimes it also just happens purely out of logistical issues. Sometimes there's a limited ability to intervene in multiple places at the same time. Some interventions are difficult and require an implementation team to go in, and you may not be able to provide 20 different implementation teams to implement at the 20 intervention sites at the same time. So you have to phase it in. And that means you literally can't physically do a parallel trial. Next. So one myth that I hear, at least in my view, it's a myth, is that the benefit of stepped wedge designs is that each cluster or site is acting as own control. And I would say if this were the case, we could all get away with doing pre-post studies, which most reviewers hate, because the Achilles heel of pre-post studies is someone will always say, well, what if they were going to improve anyway? And when you just do a pre-post, that's not something you can answer, because things might have happened whether or not you intervened, or the intervention may have been totally irrelevant to why there was improvement. So I think my version of the truth here is that it's not that you get to use each site as their own control, but it's that, for example, in the previous stepped wedge, for all of 3 sites, you're collecting baseline data on a rolling basis before the intervention starts. And that lets you estimate what's called a secular trend, or what really was happening anyway. And then when you analyze a stepped wedge design, the most common way is you model it to see essentially if there was an excess improvement after intervention compared to what you estimated as the secular trend. So you can estimate that vaccination rates were improving, for example, over time. And then the question is, did the intervention give it an extra kick so that it happened faster than it seemed to be doing over time anyway with the intervention? Next slide. Having technical difficulties. I'm seeing a lot of comments pop up, which I wish I could read and think at the same time. And a lot of them seem to be much more detailed ones about analysis and estimating ICCs, which are great topics, but I'm happy to talk about those in questions if people want to. No need, are we stalled? There we go. So I just want to show you, this was the example of a power analysis I did, I think actually for the same stepped wedge trial that I showed in the figure. And what I wanted to say was power for stepped wedges are more complicated than for cluster randomized simple trials because, as you can imagine, you have to estimate different kinds of secular trends, different estimates of what you think your main effect is going to be. It depends on how you're going to model the main effect. Do you think that there's going to be a different time trend over time after intervention and for places that have already started the intervention if you continue them? So a lot of times, I think the way most people do them, the way I have done them, that makes the most sense is to use simulations. So you really want to come up with a variety of scenarios. This one, I think the top panel this was a UAB study. So the top panel was looking at UAB with 10 practitioners at UAB, and there were a couple other sites. The middle panel was if UAB could find 12 practitioners and other sites. And the bottom panel was what if we could only do it at UAB with 12 practitioners and couldn't get the other sites at all. So there were a couple scenarios of the main effect. Those are the color-coded lines. I don't really think anyone should pay attention to these things too much, but it was just to show that there's a whole range of scenarios. And this, I don't think, even went into different levels of ICC between things where we had different scenarios for those, but there's only so much you can put on one plot. But I think the y-axis was power. Those horizontal lines are where you cross the 80% power line and the 90% power line. And just shows you that things were very different. Looking at the bottom panel, if we only had one site, we actually had a harder time making it up to power, and it required a whole lot of patients per site. It was a lot better if we had more sites. Next slide. So maybe I should put the words before the figure, but essentially this is it. Like, it has all the same issues of a simple cluster randomized trial, but more because it requires working assumptions of what your time trends are in addition to intercluster correlations and how you want to test your hypotheses. And really, it's a matter of lots of simulations. The more assumptions you make, the more particular any particular power calculation is. I think it takes looking at a variety of scenarios and trying not to be too optimistic. Next slide. And that was it. So I think we're happy to talk about questions if people have them.
Thank you, Navni and Joshua. This was such a great presentation, and there are some questions in the chat. I'll start with one from, and feel free if you want to come off of mute and on video if you want to ask yourself. But first one is from Robert Parker. Is there a reference for the maximum effective sample size is about 1 over ICC?
I think the short answer is yes. What I know off the top of my head, no. So the ordinary formula for what's called the design effect is that the design effect of clustering is 1 plus the interclass correlation times 1 minus the cluster size. And so that gives you sort of how big an impact it is. The effective sample size, and I think most of this is in Murray's book, is the one that I've used the most, but I've done this now so many times I don't usually have to look it up. The effective sample size, you take your actual sample size and divide it by the design factor, and that will usually tell you your effective sample size. And if you look at the formula of 1 over the design factor, you can see that as n, the size of your cluster, gets bigger and bigger and bigger, that factor maxes out at 1 over the ICC. So that's roughly how you get there. It's kind of surprising and also extremely frustrating when you are designing a trial for somebody and they think they have lots and lots of patients, and then you look at the interclass correlation and realize that you have lots of patients but not a lot of independent information.
Thank you. And then we have a question from Nadia. Can you speak to how to adjust step-wedge designs when there's a lag or a latent period from when the intervention or strategy is delivered and when the effect can reasonably be expected?
Yeah, so that is a really good question because, a lot of times we design trials as though a switch is flipped and suddenly you reach maximum intervention effect. So a lot of times some people will essentially skip the data during the initial implementation period so to allow it to be a reasonable step. Another way is you can model the effect of an intervention in terms of the duration that each group has been exposed to the intervention. So you could decide that your main hypothesis test is after 2 periods of intervention exposure. You are comparing that to previous intervention adjusted for secular trends. So there's lots of ways to do it. And I think one of the biggest advantages of doing your power calculations with simulations is it really makes you think through how you're going to analyze your data to begin with. So if you decide to design your study using simulations, you have to make these kind of decisions along the way of like, what is my data going to look like? How am I going to measure it? How am I actually going to model it? And then you run your simulation 800 times and see how many times it's significant. What you want to test is significant under each sort of set of assumed conditions.
And then from Abraham, how do you calculate ICC during sample size calculation?
So if you have pilot data, there are packages in R that will do ICC and ICCs for binary data. It's actually interesting. There's not one universally accepted definition of the ICC, but the most commonly one used these days, and this is like one of the people who can't tell their right from their left, I'm probably going to mess this up, but the ICC, the most common definition is the proportion of the variance that is between clusters divided by the total variance. So, and it's a little counterintuitive to talk about the between cluster variation, but essentially, I don't know if y'all can see my hand, but if you've got little clusters over here and they're far apart, there's a lot of variability that comes from between the clusters and a little bit of variability within each cluster. So that tells you that within each cluster, people are a lot more similar to each other than they are to all the clusters all over the place. And then, of course, it gets a little more complicated when you talk about binary outcomes, but there are lots of different and reasonable ways to do that. And thankfully, software makes it so you don't have to suffer through it yourself most of the time.
And then the last question in the chat is from Emily. So ideal analysis of step wedge is something closer to DID?
Interrupted, sort of difference in difference. I think that is a fair assumption. Yeah. So really, you're looking to see whether things change differently in one group than another. Philosophically, that is very much like a difference in difference. The thing is, here, every group is being subjected to the intervention eventually. So you're really looking at a time sequence estimated and then a little bit extrapolated from the unintervened over time, and you're looking to see, does the time expectation change after intervention? So yeah, it's very similar.
We have 2 minutes left if anyone has any final questions to
I'd
ask.
also say there's probably no ideal stepped wedge, but yeah, that's the usual.
Any other questions? Well, thank you both for sharing your expertise with us today, and to everyone who joined us. And we hope that you all will join us again in our next webinar next month. Thank you again to Navneet and Joshua for your time. This was really great.
Thanks.
Have a good day.